Dr. Tanya Kapka is a board-certified family physician who's been doing primary care at FQHC centers for her whole professional career. She attended OHSU for medical school, Harvard School of Public Health for MPH, and did family medicine residency training at Lawrence Family Medicine Residency in Lawrence, Massachusetts. Last 11 years have seen her at Virginia Garcia Memorial Health Center in Hillsborough, where she served as lead clinician for 6 years and is part of the residency faculty. Until recently, part of her practice was doing hospital obstetrics at Tuwality, providing prenatal care using the centering pregnancy model. She is fluent in Spanish. Her research work has largely been with the Kaiser Center for Health Research here in Portland. She has been here at CareOregon for just under 2 years, working with our network, serving as medical director for the metro area. I just want to say we're able to put on programs like this and interact with the community because of the enthusiastic support from CareOregon leadership. Dr. Kapka is one such leader. Please welcome her to the stage.
Thank you very much. Is this working? Yes? Okay. Thank you for the introduction, Paul. I really appreciate it. I'm really excited to have such a full room. This is our biggest MEDS Ed event ever. And so I just want to say this really looks like a tipping point to me, particularly seeing a combination of both behavioral health as well as primary care and probably a few other representation here really coming together because we know this is an incredibly vulnerable patient population that we're talking about here, and we're all seeing them in a lot of different places in a way that's not as coordinated as we would like it to be. In many cases, really not as coordinated as we'd like it to be. And so what I just wanted to talk a little bit about is when I hear about a problem like this, I immediately start thinking about systems because I'm not an MAT expert. I am a systems and implementation person. So really, I focus a lot, and with our team here, on working with our network to help things land so that our patients really get what they need, and that they're, like I said before, that they're in the right place, that they get what they need at the right time, and that the right people are wrapping around them and helping them on their journey. So that's where I'm starting from. I feel very passionately about the care of this patient population that we're all serving in the safety net. And I really want to make sure that we're all focused on the fact that evidence-based treatment is really where we need to start, thinking about what does the evidence show, and then getting to the point of, okay, so the evidence shows this, we should probably change something. How do we change the fact that people want to come to work every day and know what they're doing? And what are their daily habits? And what are the things that they're doing that are actually not helpful? And how can you make changes in their daily habits that will actually, over a large population over time, truly make the impact that you need? And that is what implementation is, and it's really not easy, as it turns out. So that's just my impassioned plea for don't forget about the devil being in the details, as Paul said. Okay, so I have some slides. They kind of do talk a little bit about what our framework is for our CareOregon Metro team, and acknowledging that, yes, we are the physical health plan. We are extremely committed to effective behavioral health and care coordination with our behavioral health buddies in the specialty world. And we have a lot of buddies, which I really, really appreciate, many of whom you've heard from today. So the Quadruple Aim is one of the frameworks used in primary care when we're talking about healthcare transformation, which is really getting our teams to be able to do what our patients need in the primary care setting. And the Quadruple Aim, there's 4 points, obviously. The first one is enhancing patient experience, and CareOregon is very committed to doing payment models that support team-based care, behavioral health integration, and healthcare transformation more broadly. And that is what Stacy and a number of other folks on our team really do out in the network. Improving population health is the second principle of the Quadruple Aim. And some of the things we're doing that may be relevant to this work we're talking about today is focusing on ED and hospital transitions. We have a lot of work going on there, and includes reorganizing some of our internal CareOregon departments to better serve our population as well as the people who are taking care of them, particularly in the primary care network. We have a population segmentation model now where we're hoping that will be a better framework to get the right patients the right services. and that is relevant to this work. And pre-manage, I can't get through, everyone who knows me, I can't get through anything without saying something about pre-manage. Pre-manage is the only health information exchange system we have in the metro area that has access to everyone who's touching these patients. So if you're interested in any kind of transitions, hospital, emergency department, et cetera, you can build the cohort that you need to see the patient's high priority that you need to see right away in real time when they hit the ED. To me, that's really powerful. And then using those tools, we talk about enhanced care coordination. Reducing costs is a third point of the quadruple aim. Obviously, we're a payer, but there's a lot more to it, which is, there's a lot of medical waste, I should say. There's a lot of healthcare waste in the system. And so I think about crazy things that come out, like there's still people out there doing PAPs on women every year. Well, first of all, that's a lot of money. Second of all, that's a little bit invasive to be doing something that's not necessary. And really, it's every 3 to 5 years now. And so thinking about, okay, here's some guidelines. How do you translate guidelines and how do you go into health system and make sure that people are really keeping up with the guidelines? Because that's really what it is. That's an implementation issue that then creates waste that we could totally use for peers. We could take that money and use it for peers, or we could take that money and use it for the social workers that we all know that we need. There's a whole bunch of other things that are waste that will make me cry if I say them all. And then, so thinking about higher priorities, how can we think about all the total dollars that we have? And we're a Medicaid and Medicare payer, so we have a certain total amount that we have. And if we're going to think about how much we have for physical health, how can we apportion that money appropriately to provide the care that our patient population really needs, given that so many of them are incredibly vulnerable and they need a lot. And then the last thing, people talk about the triple aim even now, and I just always say it's the quadruple aim, because if we don't talk about burnout, then we're not going to really have a sustainable way to address all the needs of our patient populations. Burnout is a huge thing in behavioral health. It's a huge thing in primary care. We have, as Dr. Chang was talking about, thinking about trying to get through your day and seeing the number of patients you have to see. I mean, we see 20 patients a day typically in primary care, and some of them really need a whole lot more than that 20-minute visit that we have. So we're optimizing our teams. We're trying to make sure that we have the best supports available. And without behavioral health, I mean, I truly could never work in another primary care clinic that does not have behavioral health, because our integrated behaviorist is such a key support to managing or helping support some of our highest risk patients. And so trainings like this are helpful. Talking amongst ourselves about how to fix these barriers are really helpful, but just acknowledging that burnout is such a huge issue, particularly in this space for all of us. I think we can never forget that. So how does MAT fit? Well, we kind of all know now after today. Pretty much all 4 of these points were touched on throughout today. It does help enhance patient experience. We've had several people speak to that. Population health, definitely it can improve health of the population. We reduce death, we reduce disability, we allow people to be more functional. Reducing costs. Overall, the prescribing buprenorphine reduces utilization tremendously for ED and hospital, allowing that money to hopefully, if we do it correctly, be spent for the supports that somebody needs to continue their ongoing recovery and manage their chronic conditions. And then lastly, reducing provider burnout. Again, Dr. Chang spoke to this for the primary care perspective, but I think almost everyone who spoke today mentioned in some way how having tools available to really help take care of patients who are really suffering is what we all need to be able to move forward and stay in this work. Stay in this work for the reasons we came to it. I have trouble talking about trauma and resilience without quoting Maya Angelou. I was an English major in college, and so I think the arts are essential to life, honestly, and help us, remind us of our humanity. I'm also a huge proponent of data and evidence, and so I'd like to put those 2 things together here. If we lose love and self-respect for each other, this is how we finally die. We don't want to die. We would like to live. And I think the EMS, I just want to have a huge shout out to you guys for your Project Hope. That was really inspiring to me. Okay, so there's a bunch of stuff going on in the metro area around primary care, around MAT, SUDS. We have integrated behavioral health in many of our larger primary care sites in the safety net and elsewhere. So I'll just pick a few highlights, because I know we've all been here a long time. I hope you guys don't feel like a new diabetic who just got like 4 hours of education about how their life is going to be different. Because I'm sort of feeling that way, like, wow, okay, I have to do something. Let me just pick 2 things that I can do tomorrow. So let's all pick 2 things as we're thinking that we can do tomorrow, and then we'll keep this conversation going. So these are some of the things that are going on. One is ongoing support for healthcare transformation, as I talked about already. We are also developing, particularly with Stacy's leadership, an implementation guide to aid in operationalizing MAT in primary care. The EMR tools that were referenced, that were developed at OHSU, are allowed to be shared shamelessly for those who use Epic, and so we can be a point of sharing for that. Somebody mentioned earlier the Oregon Echo Network. Super exciting. So if those of you who are not familiar with the Oregon Echo Network, it's a statewide network that's administered through OHSU. That's a multi-week training usually for clinicians, and has a huge variety now of offerings. It's a webinar-based training, and it now awards CME credit. They've been very successful with psychiatry prescribing in primary care, so that is continually being offered. I believe that's a 12-week session. Next year, starting in January, for the first time, we'll be getting an MAT implementation in primary care session. So if you haven't signed up for it yet, we will give you the link, or you can just look on OHSU's ECHO website to sign up for that. Super exciting. There's also an addictions session that has been ongoing. I believe it's still happening right now. Yeah. Jeffrey's doing it. Also, we have worked, there's been support from CareOregon for programs like Impact and New Directions that are hospital-based, and you know, we just find that linking those types of programs, as well as folks we have a couple social workers at Unity, at the emergency services portion of Unity, who help link people to places like CODA and DePaul when they show up there. And there's a couple models in the metro area, Hooper and CODA developing one of them. There's one in development, that one's pretty robust, but there's one in development through OHSU, and then there are a couple other hotspots of innovation for really trying to coordinate services, again, to meet the needs of patients when they need them at the correct place. And then payment model, we're really working hard on enhancing our integrated behavioral health model for next year. I already mentioned Unity. And then opioids, just a lot of focus. We do a quarterly review within our primary care network to continue reducing the high-risk prescribing. This slide is my only data slide. I usually do like a lot of slides with data. This one is the most descriptive one I have that says something very hopeful about our network. So if you look at quartile, or sort of 4 chunks of prescribing already in the network that CareOregon is paying for currently, what's important about this slide is the really big bars on the left, which is 0 to 10 patients being prescribed to, and each bar is a year, 2015 to 2018. The small bars are in the 11 to 20, 21 to 30, and over 30. And this tells me we have a lot of opportunity for even those who are already X-waivered and already have prescribed at least one prescription, that we could, if we had better supports for those folks out there, they could prescribe more. And so this access problem that we're talking about, let's do as best we can to provide folks what they need at the site where they are, so they can increase the prescribing that they're already doing. I really like Dan Larson. And this talks about poetry, which is great. I'll let you read it. Okay, so this is relevant to what I'm talking about. And the way it's relevant is because that electric fence is kind of how each of our EMRs works. So we each have an EMR, right? And that is the electronic environment that we live in. And we can't see anybody else's stuff. So if I have a patient in front of me, and I can see all of my stuff, and yay, we have Care Everywhere, which has been honestly a game changer. So now, since I'm in Epic, I can see what's happening at hospitals now, which is amazing. And in some cases, some specialists. What I can't see is anything going on behavioral health at all. And so, why am I promoting pre-managed? Because my EMR can't see what you guys are doing in behavioral health, and I really need to know who needs help in my patient population. And if I'm not seeing them, I want to know who's assigned to me, and they're not coming in, but maybe they're engaged with behavioral health, and then they hit the ED, and then I find out about them. That's how pre-managed can help. Again, until we are all in the same EMR, or until we have a portal that follows a patient around, which is kind of what we really need, we are going to be saying this, damn the electric fence. So anything we can do to talk to actual people to enhance our care coordination can only help better serve our patients. Hey, I get a poll too. So, next steps. So what do you all need? For those of you who do primary care, do you want to prescribe? You're unsure? You want to better understand about referrals? We're prescribing and we just need a little help, or everything's going awesome? All right, well, we're full. So the people who answered most quickly tended to hit D. Okay, good. That is great, because that's the part we are most poised to help with. So thank you for your responses. At the end, we'll give you some resources, and there's also a resource list in your folders talking about support for prescribing, for just getting your staffing model to work. I have another one. I want to prescribe, I need some technical assistance, and these are some of my needs. If you could just tell us what kinds of needs you might have. This would help us better support the network out there.
You needed all of the above. Exactly.
Oh boy.
They don't know. They
That is a totally damn the electric fence. Yeah. It's a special protection for people with SUDS. Wow, this is a great spread. This is really helpful to our technical teams, because hopefully after this session, you all will contact us and ask us for help, and we'll know better how to direct our resources. I think G is what we all need. Okay, last one. I'm unsure. I need some information. These are the things that I'm most worried about. Wow, this is great. This is really helpful. This is kind of following a pattern that we already suspected. So we have developed pieces for almost every one of these. And again, you'll see some of those listed in your resources. We will continue working on the payment model, obviously, and trauma-informed care. I'm glad that people are picking that one as well. Until we have a fully trauma-informed workforce, it'll be hard to really move forward full steam ahead. So that's something that we would love to connect you to as well. So this is basically just saying we can help. Stacy would be our main point person if you're interested in technical assistance. Her information is in your packet, as is my own. There's some basic resources for MAT implementation. This is also in your packet. Quality means doing it right when no one is looking. I think we're all committed to quality, or we wouldn't be here. Let's make sure that our systems support doing the right thing whether or not people are looking. Here's just a few more broader resources for primary care. Although the world is full of suffering, it is also full of the overcoming of it. Helen Keller. That's why we're all here today. Thank you so much for being here.